Okay, so today's lecture is going to be on chapter 4. This is on radiation biology. Starts on page 31 of your dental radiography textbook. Some of the objectives that we're going to cover are how radiation damages cells. You'll need to differentiate between short and long-term effects of radiation damages, and then understand the exposure risks of dental radiation. Okay, and then we're going to outline these things for radiation biology, which are injury, effects, measurements, and risks. So the purpose of this chapter is to describe the mechanisms and theories of radiation injury. So a lot of the stuff in this chapter can be a little scary. So I want you to understand that in dentistry, we actually use very small or very low levels of radiation. But you'll need to define the basic concepts and the effects of radiation exposure. And then you'll need to detail the radiation measurements, and we'll also discuss the risks of radiation exposure. So first of all, let's talk about the mechanisms of injury. So in diagnostic imaging, not all X-rays pass through the patient and reach the dental X-ray receptor. Some are absorbed by the patient tissues. So it's the absorption that causes the chemical changes that result in biological damage. So this is why we can't make the statement that all ionizing radiation is safe. In fact, the way the chapter starts out is it says that all ionizing radiation are harmful and produce biological changes in living tissue. Okay, so we have to be aware that ionizing radiation does and can affect the way tissues function. So there are two mechanisms of radiation injury that are possible. The first one is ionization, which we just talked about. Another one is something called free radical formation. So ionization results from, as we know, when the X-rays strike the patient tissues. And this can be done through some of the effects that were discussed in chapter 2, which are the photoelectric effect, which is absorption, and the Compton scatter, which is a type of scatter radiation. So this results in the formation of a positive atom that's left behind, and then we have a dislodged or a negative electron that got bumped out. So this results in a different type of ionization than what was discussed before. So before we discussed ionization in terms of the anode where the X-ray is produced. Now we're talking about ionization in terms of cellular formation or cellular damage. So the electron that got booted out is what's called a free radical, and that will interact with other atoms within our tissues, causing chemical changes within the cell that results in biological damage. So with free radical formation, cell damage occurs primarily through the formation of free radicals. And free radicals are formed when an X-ray photon ionizes water. And if you think of the human body, most of it is water. So a free radical in the human body, or any body to be frank, is going to be very dangerous. A free radical is defined as an uncharged atom or molecule that exists with a single unpaired electron in its outermost shell. Atoms want to have at least 2 electrons in them at all times, or they're going to want to have an even number of electrons. So if you have an atom with only 1 electron, it's going to be highly reactive and highly unstable. So the theories of radiation injury are going to fall into 2 groups. One is the direct theory and one is the indirect theory. And those are going to be discussed on page 31 and 32. The direct theory is when cell damage results when ionizing radiation directly hits critical areas within the cell. So this doesn't happen very frequently, and the reason being is because most of the X-ray photon radiation passes through the cell and little damage is actually made. The indirect theory happens when photons are absorbed within the cell and cause the formation of toxins, which in turn damages the cell. So when the X-ray photons are absorbed by water within a within a cell, a free radical formation results. It's that free radical that combines to form toxins that damages cells. So in science, graphs are used where dots are plotted on the graph to show a certain relationship of certain things. In this case, a dose response curve is used to correlate the damage of tissue with the dose of radiation received. So if all ionizing radiations are harmful and produce biologic damage, the question is what level of exposure is considered acceptable? A dose response curve is what's going to be used to establish what is acceptable and what is not. A dose response curve can be found on page 33 on figure 4-4. A couple of key points that you're going to want to remember. A linear relationship indicates that the response of the tissues is directly proportional to the dose, where a non-threshold dose response curve suggests that no matter how small the amount of radiation is received, some biologic damage occurs. So this suggests that there is no safe amount of radiation exposure. And although the doses received by the patients are low, damage does occur. So the next two terms are going to describe, the first is going to describe the function of the dose, and a non-stochastic effect describes the effects on the somatic cells. So the first term that we're going to be looking at is called stochastic effects, and that can be found on the bottom of page 32. And what that is talking about is a direct function of the dose, and that the dose has no threshold, or its effects do not depend on the magnitude of the absorbed of the absorbed dose. Some stochastic effects can cause some serious things like cancer and genetic mutations. So the second effect that we're going to talk about is a non-stochastic effect, or the deterministic effect. These are effects that are going to have a threshold, and effects increase in severity with increasing absorbed dose. Some of these examples are going to look like erythema, which is just redness of the skin, loss of hair, cataracts, and decreased fertility. So moving right along, we're going to start talking about the sequence of effects of radiation injury. So latent period is a term that you'll definitely want to know. This is the time that elapses between exposure to ionizing radiation and the appearance of observable clinical signs. So you can think of a latent period when you think of catching a cold, right? So when we first are exposed to a cold, there is a time between that point when we're first exposed to when we start seeing observable signs and symptoms like sneezing, coughing, runny nose, sore throat, etc. The same thing happens with radiation injury. There is a latent period. So there is a time between a high dose of exposure to radiation and the appearance of clinical signs like red skin or hair loss and things like that. And then this is going to depend on the total dose of radiation received and the amount of time it took to receive the dose. And then we have to take into account a period of injury, which is a variety of cellular injuries that may result. And there's a recovery period. Although our cells and tissues have an amazing capability to repair themselves, there are a few factors that play a role in how quickly or how likely cells can repair the damage caused by radiation. We also have to be aware that the effects of radiation are cumulative or add up over time. This is because unrepaired damage accumulates in the tissue. There are also some factors that we want to note that are going to help us assess the radiation injury. So these factors can be found on the bottom of page 33, and we're going to go through each one by one. A total dose refers to the quantity of radiation received or the total amount of radiation energy absorbed. So more damage occurs when tissues absorb large quantities of radiation. A dose rate is when exposure to radiation occurs and absorption takes place. More radiation damage takes place with high dose rates because a rapid delivery of radiation does not allow time for the cellular damage to be repaired. So this is why in dentistry, we're going to have exposure times, or actually, so when a patient comes in for x-rays, there's going to be a certain amount of time elapsed before we go ahead and take x-rays again. So usually that's at least 6 months to a year. That will give those tissues or those cells that time that they need to heal after taking or having been exposed to ionizing radiation. The amount of the tissue irradiated is also going to be important. These are areas of the body exposed to radiation, and total body irradiation produces more adverse systemic effects than if just a small part of the body is exposed. So in dentistry, the nice thing about it is the PID that we use that comes out of, or the irradiation that comes out of the collimator is actually very small. So only a small focused part of the body is actually exposed to that ionizing radiation. Cell sensitivity just talks about the fact that in the human body, there are certain cells that are going to be more sensitive to radiation than others. And age is also going to be an important factor because children are going to be more susceptible to radiation damage than adults. So some of the radiation effects that we're going to be talking about are found on page 34, and they're going to include short and long-term effects. And somatic effects are going to deal with cells that have to do with our own cells in the body. And genetic effects are the cells that are going to be used in our reproductive systems that are going to be passed down from generation to generation. And how radiation affects cells, tissues, and organs. So let's talk about some short and long-term effects. So short-term effects are going to be associated with large amounts of radiation absorbed in a short amount of time. So we can think about an atomic bomb going off or a problem at a nuclear power plant. So you'll also want to know this acronym ARS. It stands for acute radiation syndrome. And that's a short-term effects where you're going to have some of the symptoms that include nausea, vomiting, diarrhea, hair loss, and hemorrhages. These are going to be effects from that short-term effects where large amounts of radiation are going to be exposed. I just want to note that short-term effects are not really applicable from the amount of radiation that we're going to be using in dentistry. Long-term effects are associated with small amounts of radiation absorbed repeatedly over a long period of time. Repeated low levels of radiation exposure are linked to the induction of cancer, birth abnormalities, and genetic effects. So with radiation damage, there are two types of cells that can be affected. The first are going to be known as somatic cells, and these are all the cells in our body except for our reproductive cells. Our genetic cells are all the reproductive cells. So biologic effects of radiation can be classified as somatic or genetic. Somatic effects talk about are they're seen in the people or the person that's irradiated, and they're not seen in future generations. So if I were to go ahead and get sunburned and consequently skin cancer from overexposure to the sun, that doesn't mean that my daughter or my future grandchildren will have those same effects. Genetic effects, on the other hand, are not seen in the person irradiated, but seen in future generations. So if you or somebody else is being irradiated in the dental office constantly, where your reproductive organs are constantly being exposed, this can be a situation where you're not going to be necessarily affected, but any children you have and any children after that can be seen with some of these genetic effects. When talking about radiation effects on the cells, a cell that is sensitive to radiation is termed radiosensitive, whereas one that is resistant is going to be called radioresistant. And the response is going to be determined by these three factors that you see on the slide. They can also be found on the bottom of page 34. Mitotic activity just talks about how the cell divides, Cell differentiation talks about how cells that are immature and less specialized are going to be more sensitive to radiation. And also cell metabolism is going to be an important factor. And cell metabolism just means that cells that are going to be more active or have a higher metabolism are going to actually be more sensitive to radiation as well. When talking about radiation effects on tissues and organs, there's going to be certain organs and tissues that are going to be more radiosensitive and certain tissues and organs that are going to be more radio resistant. And it's going to be important to know which ones are which because they are potential questions on the RHS exam. So you're going to want to know which organs are going to be more sensitive to radiation and which organs and tissues that are going to be less sensitive to radiation. So anything that has to deal with the lymph or lymph nodes are going to be highly radiosensitive organs. Also, anything reproductive like testes or ovaries are also going to be very radiosensitive, as well as bone marrow and intestines. Some radio-resistant tissues include salivary glands, the kidneys and the liver. A critical organ is an organ that, if damaged, diminishes the quality of a person's life. And there are going to be 4 critical organs that we're going to be dealing with in dentistry. The first is going to be the skin, which is around the face and the head of your patient. The thyroid glands, which is sometimes in that direct primary beam. Also, the lens of the eye can sometimes be in your primary beam, as well as the bone marrow from tissues inside the head and neck. So radiation is measured in units of measurement that are established by the International Commission on Radiation Units and Measurements. So although this is going to be important for you to know on the RHS exam, in dentistry, we are not going to usually be measuring radiation in this way. So there are some older or traditional units of radiation measurement that we'll be talking about. A Roentgen or an R is a way of measuring radiation exposure by determining the amount of ionization that occurs in the air. A radiation absorbed dose, or a RAD, refers to the amount of radiation absorbed dose, or the amount of radiation that is soaked in by the tissues. The Roentgen equivalent in man, or REM, is another older version of measuring radiation. And the actual definition of the REM is the product of the absorbed dose and a quality factor specific for the type of radiation. So this is more of an equation that is used to measure the factor of the absorbed dose and the quality of the specific type of radiation. There are newer units of radiation measurement, and the column, or it's called coulombs per kilogram, is a unit of electrical charge. This measures the number of electrical charge, or the number of ion pairs in 1 kilogram of air. A gray can be related to the radiation absorbed dose in this way. So 1 gray equals 100 rads, or 100 radiation absorbed doses. Likewise, a sievert is related to the Roentgen equivalent in man, or REM, such that 1 sievert equals 100 REMs. So going back to sort of what I just said, Roentgen measures radiation by determining the amount of ionization that occurs in the air, and it does not describe the amount of radiation absorbed. And just note there is no SI equivalent to this, and exposure is stated in coulombs per kilogram. And then also again here, 1 rad is the amount of energy absorbed by tissue, and an SI equivalent is the gray, where 1 gray equals 100 rads. And also, once again, the REM, or Roentgen equivalent man, is a dose equivalent measurement that is used to compare biologic effects of different kinds of radiation. And 1 sievert equals 100 REMs. Here, milli just means 1/1000th, and it is used to express the small doses used in dental radiography. So now we're going to be talking about the radiation risks. So sources of radiation exposure, risk estimates, dental radiation and exposure risks, patient exposure and dose, and risk versus benefit of dental radiographs. So if dental radiographs are dangerous, then why would we expose them in the first place? And what benefit do we get from exposing them? So some of the sources of radiation exposure, one is going to be natural background radiation. And that's a form of ionizing radiation that is ubiquitous or kind of everywhere in the environment. And this can come from cosmic radiation, which includes the stars and the sun, and also terrestrial radiation, where radioactive materials in the earth and air. In the United States, the average dose of background radiation received by an individual is somewhere between 150 to 300 millirads per year. Okay, and so artificial or human-made radiation comes from consumer products, fallout from atomic weapons, and from nuclear fuel. Medical radiation also causes this type of exposure, and this is going to be the radiographic the radiographic procedures such as dental radiography, and then also covers the nuclear medicine that covers radiation therapy for cancer patients. Risk and risk estimates. So how do we estimate the risk that's involved when exposing dental radiographs? So the potential risk of dental radiography inducing a fatal cancer in an individual has been estimated to be 3 in 1 million. The risk of a person developing a cancer, on the other hand, is much higher if they got that cancer from radiation elsewhere. And this is going to be estimated to be about 3,300 in 1 million. So you're going to have more of a chance of getting cancer from some other source of radiation than you would by exposing dental radiographs. So the book talks about other risks that you might take and how likely you are to die in participating in one of these activities. So there is a 1 in 1 million chance that you will die by riding on a bike 10 miles a day, driving in a car 300 miles a day, or riding on an airplane 1,000 miles a day, or smoking just 1.4 cigarettes a day. So once again, you do want to be aware that there are some areas of the body that are going to be especially sensitive to radiation, and they are going to be considered high risks if they are going to be in the path of the beam. And these are going to be the thyroid gland, the bone marrow, the skin, and the eyes. So patient exposure and dose are going to be important factors when talking about minimizing the risk to cellular or tissue damage by X-ray radiation. So the first is going to be film speed. And if you do have to work in an office that is still using film, make sure that they're using only F-type film, as this is going to be the only speed that's going to be acceptable for shorter exposure times. The type of collimator that you use in your office is also important. So a rectangular collimator is going to be less riskier than using a circular collimator. And this is because a rectangular collimator is only going to be about the size of a number 2 sensor. So you're going to be reducing that the total exposure area to your patient. The techniques that we're going to be using are also going to be really important, because the technique that you use is going to determine how well how well the quality is of the X-ray that you take, and that will determine whether or not you have to go back in and take even more X-rays to get the correct image. And then you also want to make sure that you're setting your exposure factors well, so that they are going to be the correct settings for the type of images that you're trying to take. So the risk versus benefit of dental radiographs talks about how dental radiographs should be prescribed for a patient only when the benefit of disease detection outweighs the risk of biologic damage. So having said that, when dental radiographs are properly prescribed and exposed, the benefit of disease detection far outweighs the risk of damage. So without dental radiographs, we couldn't detect things like caries or cavities or bone loss or infections or even certain types of tumors. But what's going to be important is that these x-rays are needed or prescribed by your doctor rather than taking them just because of office policy. And that concludes our lecture for chapter 4. Thanks for listening.